Hey guys, Coach Bricks here. I'm with my man, Dr. Joe. Doctor, what's
At it
up,
again.
buddy?
Yes,
That's
sir.
right, RX Health and Fitness, buddy. We wanted to talk about it because you get a lot. I get a lot of questions. I know you probably get tons, and you see patients. The big thing, probably one of the biggest epidemics outside of obesity, is diabetes. But it's usually a cause of obesity. Usually leads to diabetes at some point. I wanted you to break down because people don't know that there are really three types. We're going to talk about the three that we talk about, but two that are main. I want you to break down the two that are main that most people have, and then we'll discuss the one that's more or less known worldwide as a type 3 one, not so much here in America, but worldwide we call it something different. So, what do you see as type 1, 1.5 that you call it as? What does that entail? Well, how is somebody diagnosed as type 1 compared to type 2?
Okay. And what David is alluding to in terms of we're talking about diabetes and the types or subtypes of diabetes, where diabetes, the definition, discrepancy or fluctuation or abnormality with control of blood sugars for one reason or another. So we're dealing with blood sugar, but when we're dealing with the subtypes, it's what's causing those fluctuations or the lack of control of blood sugar. To get right to the point, what we know, or some may have referred to or heard about as juvenile onset type 1 diabetes mellitus, okay? The reason why they name it as type 1, or you may also hear as insulin dependent diabetes mellitus, okay? This is an individual for one reason or another. There's many different sources or causes for it, but often what we see in a younger individual is something usually occurs from an autoimmune involvement where their immune system reacts or attacks their pancreas. The pancreas responsible for putting out your insulin. So what they have found is something shorts out the insulin or the islet cells, the beta cells in the pancreas, that does not allow a person to secrete the sufficient amounts of insulin. Or in a child that is truly diagnosed as full type 1, unfortunately, they barely put out any output. So that is why, it's often hard or life-changing when a person's saying, wait, you mean for the rest of my life to keep my sugars in control, I need to be on insulin? Although you hate to say absolutely no, you're at jeopardy of lying to that patient and hurting them if you say, hey, likely, yes, definitely lifelong, you're what they call an insulin dependent diabetic. Now, why? Whether they are consuming little to zero or all carbohydrates, they're still with different metabolic processes, whether you're having high amounts of proteins or saturated fats, you still can spike your blood sugar levels in different metabolic pathways that we found that. So even if a person is saying, look, I won't have another drop of sugar the rest of my life, are you telling me I may still have to use insulin or monitor my sugars like that? Absolutely. About the awareness. It's unfortunate that the initial powerhouse, the pancreas, has been shorted out. You see that most often in young individuals or before they get to their adolescence or early adult years.
Now, just to break that in, do we know why that occurs? Or is it just like, well, it happens to this individual that? Is there somebody who's predisposed to it or, at a higher, maybe their gene or something like that?
There are some genetic or family predispositions that do relate to a person being at a higher risk. Okay, so usually in the clinic setting, we review: are there any first degree relatives? Okay, someone within the immediate family, like a sibling. Okay, not a child if we're talking about diabetes type 1, because it's often in the early onset, not all the time, but parents or grands. Has anyone dealt with diabetes or type 1 diabetes? Okay, that a person can have a little bit of a genetic predisposition. Okay, and they are still narrowing down to those specific genes that have been attacked, but still they don't have the full correlation that it is going to definitely be passed down from generation to generation in that gene pool or bloodline. Okay, but there's just a higher probability. Other sources and causes where, like I said, they found more so often a child will have a bad virus, come down with a flu, or came into contact with a mononucleosis or cytomegaloviruses. These are viruses that can cause a change in illness, and for some reason It just attacks or causes a person's immune system to want to react not only to that virus, but react to those pancreatic beta islet cells and cause a shortage. Okay, so, those are two of the most common sources. A person, despite the contrary, a person can't eat themselves into type 1 diabetes. More specifically, it's unfortunately organic process that has occurred, or an inorganic process as we call it, that has started to cause that change with the body.
Now, what can a person do though? Say, okay, most people will have to take insulin, most likely, correct?
Uh-huh.
Is there anything else they can do to help mitigate? You said, they're not going to be able to cure it by not eating sugar and all this kind of stuff, but is there something they can do on their own to also help the process?
Absolutely. A person then being aware of their condition. What you find out, everyone over the course of their life, they find out that there's something they have to focus on that maybe affects them more. Okay, me personally, it's always been my heart. So although I don't want to be on heart medicines, what can I do to keep my blood pressure in check, keep my lifestyle in check, so I don't have to worry about heart failure? Okay, that's just personal. Same thing for a person. If it's sugars is the name of the game, you may not have to institute or inject yourself with as much insulin if you are watching, number one, your carbohydrate load. Okay, exercise is also a way that, for anyone, whether diabetes or not, and when it comes to sugars, the more active we are, the better we utilize, burn, and break down those sugars. And then guess what? We don't need to have insulin to bring down our sugar levels or cause for storage of the excess glucose. Okay, so most commonly, it is associated with better control with a lower weight BMI. But if you also see a lot of type 1 diabetics, that's what makes this so different. Most children, when they're type 1 diabetics, these are children that were already lean. For some reason, they were having symptoms of increased frequent urination, abdominal pain, diarrhea, and then you go find out, you go in the hospital, oh, when did your child become diabetic? What do you mean? This is the first time we're ever hearing about this. So it's often not associated with a weight or dietary cause for, but prevention on the back end, for better control, absolutely. Keeping a hold of our diet and our physical lifestyle are, I say, pro-insulin methods. That meaning, when I say pro-insulin, being able to use instead of in place or have as much. So a person may not require as much. Okay, absolutely.
Okay, all right.
Yeah.
Now let's get on to this type 2. Mm-hmm. All right, because this is the most common. I think 95% of most diabetes are considered type 2.
Yes.
Somewhere in that range.
Uh-huh.
What is type 2?
Uh-huh.
What can people do?
Uh-huh.
To not have to take medication their whole life.
Uh-huh.
What do they need to change? And then why is it so prevalent?
Yes. Now, type 2, Dave, compared to type 1, I love dealing with type 2 diabetes because you're right. The more we are aware and the more we do, the less you need. Okay, so that is true for a person of type 2 as opposed to a type 1. Type 2, if you hear about the notion or you hear about now insulin resistance. What is insulin resistance? Okay, so a person with type 2 diabetes, they do have a pancreas that is still active in producing insulin. Okay, there's either some things going on with that process because a person's diet or weight or appetite is causing more surges and spikes in output of insulin to bring their sugars down because their sugar levels are higher on average because of diet, reduction of exercise, obesity. Okay, the pancreas is constantly putting out this insulin to bring the sugars down. Okay, that after a while, it's kind of like I give the example, it's like a yelling parent to a child. Okay, the first time you yell at a child, not that I've ever done this, the first time you yell at a child, they look. Okay, if you're always caught yelling, the child guess what, gets used to you yelling. It doesn't spark them anymore. Same thing with the body. You're always putting out these higher spikes of insulin to bring the sugars down. Yeah, the body responds early on, okay? And actually that's fat storage. Insulin allows your body to extract the sugars from the blood and store it in your cells as adipose tissue, convert it to fat, okay? But also with that process, as you're putting out a lot of insulin, the body starts to say, hey, it doesn't pay attention to it. It doesn't cause the effect. So your body actually starts to resist the insulin. Early on, or relate it back to a child or a child with that adult. Early on, you're yelling, Okay, the child's not paying attention. You find yourself yelling more and more and more to try to get their attention. What you're doing then is you're putting out more and more and more insulin. Okay, because guess what? The body's not paying attention. So you're putting out more and more insulin. Body's not paying attention because in the middle, this thing called resistance, insulin resistance. I tell a lot of people in the clinic, insulin is what? It's a growth hormone. It's a growth factor. Okay, insulin is needed in high amounts, especially for children that are growing, because guess what? That causes them to want to grow. We as mature adults, when we reach our full maturity height-wise, and we're not really elongating our bones and growing, we have to watch it, because then when we grow this way. Okay, but for a child, insulin is different. Insulin growth factor or insulin output. Okay, as an adult or late onset diabetes mellitus, or someone that you see this transition as a fact over decades or years, okay, in a person, you start to see type 2 more often in individuals late 30s, starting really into 40s, 50s, 60s, you know, been dealing with them for a while. So late onset diabetes mellitus or type 2 insulin resistance. Okay.
Awesome. Now, what are some things people can do?
Excellent.
So you say I come in, yeah, I'm diagnosed with type 2. What can I do if I'm not a guy that I don't want to take medication?
Absolutely.
What can I do? Is there something I can do, or is it I'm stuck with the medication?
Absolutely. And I talk about this a lot in the clinic. Although I'm a provider there and I'm a preventionist, number one. So the goal is to educate, number one, and then try to prevent, number two. If at all fails and you still can't have a person in high risk danger and still be considered a provider that's meant to try to prevent, then that's when you institute tier 3, which is medicine or other interventions. Okay, so you do have a due diligence as a provider. You take a oath or a Hippocratic oath of do no harm, where that comes into play with the medicine as the last tiers. Hey, you can't withhold care if a person has met their maximum and they're not going to make the changes, or they can't make the changes, and you still have to make sure that you don't further disease progression. Okay, so when it comes to what a person can do with type 2 diabetes, I say number one, especially assessing a person's weight. In the clinic setting, we assess a BMI, which is height over your weight in an index, and you get a score. BMI in the medical world or clinic setting, a BMI over 30 says, oh, obesity, okay, or you're at risk of obesity. A BMI over 25 says the other O, watch it, you're in the overweight category, okay? Most generally, BMI-wise, should be somewhere between the 18 to 24 if we're in a normal weight category where weight is not relating to, okay? In our realm, what we're able to do here at Ardex Health and Fitness, we're able to take that a step further than a BMI and look at more of what we could do in the medical setting, a body fat percentage, okay, where you get an idea of how much fat mass, how much muscle mass, how much bone mass, how much water weight. Get an assessment, then you're able to assess and extrapolate a person's metabolic rate. That gives you more information, okay, in terms of with their body. But exercise, BMI number one, okay, or obesity, weight reduction. So that's something a person can do by, guess what? Few things. Doing more or consuming less. Or guess what? A combination of the two. You know, you get there better with more than just one approach. Okay, so yes, whereby moving more caloric expenditure, we do see weight go down. You do also see better glycemic control, or in layman's terms, then instead of insulin resistance, the opposite of insulin resistance is insulin sensitivity. Now your body is sensitive. Now those kids are listening to every word you say. So guess what? The parent can, guess what? Lower their voice. Okay? So what you see with the reversing of insulin resistance or improving, especially in someone with type 2 diabetes that you're dealing with, that the goal is, what can you do to lower their insulin resistance? Lowering their body weight, increasing exercise, dietary and lifestyle modifications. Okay? So things that don't cause their body to spike their sugars. Now, I've never been a proponent of all or no approach, meaning I rarely encourage in the clinic or office, like, hey, you need to be on a no carb regimen. No, that carbs are a building block of the body, protein, saturated fats. You need them just like anything else. And if you've ever been on a no carb diet for such a long time, yeah, you may be functioning, but there might not be that much going on up here because glucose feeds the brain to allow the brain to cognitively catch on and process, okay, in moderation, okay, is what I like to encourage, okay. It's needed like anything else, but guess what? Maybe a person doesn't need, you see a person when I see a person who's obese, I think of energy. They have so much energy they're carrying that their body started to store it. Fat is a high energy molecule. So when I see somebody who's heavy, I say, wow, they are energy dense. So how can they tap into that energy storage and use that to propel their day-to-day and also allow them to need less day-to-day from an energy standpoint, because we're trying to get them to utilize what they already have. You start to see shifts then in their body weight. You see no drop-offs in energy. You see less insulin resistance in there as a result.
Awesome. I wanted to hit on one more real briefly, okay? And this is the type 3 I was talking about, okay? Now, most people in America don't understand type 3. This is known throughout the world, but it's Alzheimer's dementia, okay? Because it's an insulin issue with the brain, okay? Briefly just talk about this, because this is something that we're going to actually get into in another whole podcast. I'm going to talk here about the Alzheimer's and everything like that. But what do you know about this? Because it's just becoming more prevalent in America with dementia and Alzheimer's. And I think people need to start putting things together here so we can understand, what's feeding a lot of these problems that are going on. So what do you see with the Alzheimer's dementia type epidemic that's going on?
The Alzheimer's dementia, or you said some will mention it as a type 3, but more may know about it here in the U.S. as more of what they call like a type 1.5. So we already know, we discussed about insulin-dependent diabetes mellitus type 1. We discussed about insulin resistant, okay, or non-dependent type 2 diabetes, okay. In between, why they started to call it the third subtype or 1.5 is because you have a combination of both, okay? So you're kind of meeting almost in the middle or closer to type 1 or a little bit closer to type 2, but still having features of both, okay? So a person who's in that 1.5 category, okay, a person that still, if you're able to test or do what we call a C-peptide level there, or a proinsulin level, you can test that on a person in their body. What does that look for, okay? That gives you the difference between whether the insulin in their body is synthetic or it's actually created. So a person who has a low proinsulin level there actually means, okay, their body is not actually producing insulin. So if you check for confirmation for a person that says, hey, I've been type 1 diabetic for 20 years, and you go ahead and check, and you're like, yeah, your C-peptide level is literally zilch. Yeah, they're right, okay? What we find is, so you're having a person with an approach on, diagnosed as type 1 or type 2, and you find that, hey, it's not that their insulin, it's not that their body's not putting out insulin, their body is maybe not putting out enough sufficient insulin, okay, or you move a little closer towards that type 2, but not a full type 2, okay. Yes, there's a notion of insulin resistance, but there's also a notion of, hey, no matter how much you reduce the insulin resistance, that parent is still not wanting to yell, okay. So still they're putting out a little bit of speech, but at a lower volume. So you educate that person, or hey, there's a more of a multifactorial approach for that person. So still, even with that 1.5, just like we talked a little bit about, even with type 1 and more with type 2, in that subtype 3 or that type 1.5, okay, we do see and we do find out that, like I said, there's a multifactorial approach that is needed. So still a person will benefit with what we know with exercise, with reducing not only weight reduction, okay, or fat mass, okay, or better caloric expenditure, but you do also see better utilization of their glucose, lower insulin resistance, or higher insulin sensitivity there too. That makes a great difference with this person there as well. That's from an exercise, a weight, still dietary there, even for a person. I even encourage a person, even though you're not a diabetic there, okay, or you're not a person with high cholesterol, still should we be watching the types and sources and amounts of those macromolecules that we're getting in? Absolutely, so you don't run into a process down the road. I do find a lot, Dave, the body or a person is built to deal with moderation. we fall into trouble as individuals when we err on the side of moderation. We're too on one extreme of one side, and you can see that with, say, somebody who who works hard and trains, but they're kind of too extreme for the body, that they're always injury prone. They're not doing enough recovery or balance or nutritional. You have someone also on the other end that, guess what, does nothing. So it's moderation that our bodies were built, and it's getting people back to not depriving yourself, but making them aware, educated about themselves, how their bodies work, what's more specific to them, and then encouraging a routine that, guess what, the goal is to keep this up until you meet your maker, until life. That's the goal. So in terms of the relation to Alzheimer's is the most common form of dementia. So most often hear about Alzheimer's, but it's often synonymously mimicked, but they're not the same. Dementia and Alzheimer's are not the same thing. All dementia is the umbrella of a cognitive concern. Alzheimer's is just one of the most common forms that we think about or learn about when it comes to, as I was alluding to a little bit earlier with sugars and glucose in terms of for brain health or utilization. You're right. They do know the importance, because not only is it used and burned as a macromolecule, like I said, insulin and those things are also growth hormones. Okay, so if you have somebody with a 1.5 and how it affects or relates to their cognition or their cognitive decline. If you think about it, if you have an issue on one end of the body where the body also has a little bit of insulin resistance, okay, which causes metabolic effects and changes that can affect our cognition. And then on the other full end, you have somebody who is not putting out insulin, okay, but you bring that together into that 1.5 or that subtype 3. That's what makes it a little bit harder, but not impossible, to manage and get to a longevity point for a person. You're just trying to balance this multifactorial approach. Yes, you want to reduce their insulin resistance and improve their insulin sensitivity, but you also have to be mindful of where their body is in terms of how much growth hormone they're putting out. Because again, insulin is a growth hormone. It's still used for growth and maturation and development, okay? But just in, guess what, moderate amounts.
Awesome. Well, big takeaway from this: exercise, eating the best you possibly can, getting to see my man, Dr. Joe, right? Right.
Yes.
Seeing him on his daily checkups, and then getting into RX Health and Fitness.
Absolutely.
So we can take a look at you guys and get you on the right path.
Absolutely.
Right.
And this is bringing that step together.
Yep.
It's physician-guided exercise prescription. So you're bringing together two worlds,
two worlds have been separated for too long.
Absolutely.
Now bringing it under one umbrella and putting a mesh in it so people get the best of the both and live the life they should live.
Absolutely.
Right? Dr. Joe,
hey,
always a pleasure, buddy. Thanks so much, my man.
You're welcome.
Be blessed, buddy. Guys, check us out, RX Health and Fitness. We're always going to come back with a bunch of different things, so definitely always check back. Make sure you guys, or just reach out, and all the information will be in the box, in the comment box below, guys. Be blessed.